So Tom Herzog, so in frontline, we did Prima and Pala, which was beyond BRCA. It was great. And now we're looking also in patients beyond BRCA in recurrent disease. So we have the treatment indications. We've talked about it, Recaprib, germline somatic 2 priors, Olaparib, 3 priors, germline, and then this HRD, 3 priors for Niraparib. But there are opportunities for combinations in these sort of non-molecularly signature groups. Tell us about that. I think there was one with dostarlimab and PI3K as well. Tell us about those novel combinations presented.
Yeah, so actually Niraparib.
Yeah, there you go. Yep, thank you.
Plus dostarlimab, TSR42 as I used to know it. But that's called Moonstone. So phase 2, very interesting in terms of looking at that data. So I think that, combos is really where we're going. And you see that in frontline too. And there's all kinds of theories behind that probably eclipse the time that we have to discuss them. But basically this idea of a checkpoint inhibitor with a PARP is that the PARP may increase tumor mutational burden and make the checkpoint inhibitor more effective, increasing tumor infiltrating lymphocytes and so forth. So we see a number of those things. In fact, you were talking about we have to make a choice, right, for platinum sensitive disease. Well, maybe we don't. If you look at AVANOVA, they came out with Niraparib plus Bev versus Niraparib monotherapy. Dr. Mirza presented that the PFS was 11.9 versus 5.5 months. So a significant improvement. So there's a lot of things here in terms of combinations. Dr. Konstantinopoulos presented at ESMO this year, Olaparib plus alpelisib, which is a PI3 kinase AKT inhibitor, and showed some really good data, relatively small numbers. We have combinations of VEGF with TKIs. I mean, it's just a number of things going on. We also, if we look at Topakio, we're looking in platinum-resistant disease, right? So now you're looking at Niraparib plus pembrolizumab. And in this particular trial, they showed, there's a phase 1, phase 2, and if you look at combined, the overall response was 18%. Again, these are platinum-resistant patients, and the stable disease rate was very high, 33%. So, I think there's a lot of combinations out there that are really appealing, and it really points to the need to place these patients on clinical trials, because literally we have more combinations these days than we do patients. And so it's really important that we put patients on clinical trials and figure out the very best combinations for our patients.
Yeah, thank you. And we talked about the NCCN guidelines for frontline. The NCCN guidelines preferred choice in recurrent disease is a clinical trial, to your point. So every time you enroll on a clinical trial, you are following the NCCN guidelines at the highest level. So